Thanks very much and welcome back everybody to this afternoon's session. Now, without taking up too much time, it's my pleasure to provide a little bit of background and context to this afternoon's session. At APORDE, we were privileged for many years to have Thandika Mkandawire as a lecturer on the program. As I'm sure most of you know, Thandika was a Malawian political economist who made fundamental contributions to thinking around African economic development. He held various positions, including as a director to the United Nations Research Institute for Social Development and executive secretary of the Council for Development of Social Science Research in Africa. At the time of his passing, he held a chair at the London School of Economics, having previously been professor at universities in Zimbabwe and Sweden. He passed away in Sweden, where he had lived for many years. There are numerous readings of Thandika's that you're going to be referred to throughout this course, and I'm sure that you have been inspired by his work before. So the context for the afternoon session is that in honor of Thandika's contribution to APORDE and of course more broadly, the APORDE, together with the South African Research Chair in Industrial Development, this year instituted the inaugural Thandika Mkandawire Prize for Outstanding Scholarship in African Political Economy and Economic Development, as well as a second award, the Thandika Mkandawire Prize for Young Scholars in African Political Economy and Economic Development, specifically for younger researchers. Now, this year we are delighted to have the winner of the first prize for young scholars in African political economy and economic development on the APORDE program with us, Julia Chukwuma. And we are very happy to have Julia presenting her prize-winning work to us this afternoon. We're also delighted to welcome Dr. Laura Mann from the LSE, who has kindly agreed to act as a discussant on Julia's paper. So we'll first of all ask Julia to speak to her paper for 25 to 30 minutes, and then Laura will give her input after that, after which we'll open for discussion. Thanks very much. Over to you, Julia.
Hi everyone. Thanks, Nikki, and so great to be here. And thanks for the opportunity to present my paper, and thanks to Laura for acting as a discussant. If it's okay, I'll share my screen. I've prepared some slides. I hope everyone can see that. Yeah, I mean, I've been part already over the last 2 days, so I've introduced myself on the first day, but my name is Julia and I'm a PhD student at SOAS. And so the paper that I had submitted for the prize is also part of my PhD, one of my chapters, and I've based this paper on one of my chapters. And so just to give a short outline what it is that I want to present today, it's really based on the paper that I've given, but I want to give a short introduction in terms of what my motivation is for my PhD more broadly, but then for this paper specifically, which is really one of the substantial chapters, and then speak about the trajectory of health policy development in Nigeria, kind of running you through what happened already in the colonial period in Nigeria, but also then later after independence, which I think is really important to better understand how this last new law in Nigeria's healthcare system was developed, the National Health Act. So my paper is really looking into the trajectory of health policy development in Nigeria and the National Health Act, which was adopted in 2014 in specific, in the broader light of understanding how social policies are being developed in an African context. And I have some concluding remarks, and then I'm really looking forward to hearing all your thoughts and hearing a discussion and also your questions to some of the things that I'm trying to present today. So in terms of motivation and background, really, so my whole PhD is looking into the different factors that define social policy development in an African context. And I was really motivated by having worked in the social policy sector for a few years, and everybody is speaking about social policy, social protection, social assistance, social insurance, welfare, but it's not always quite clear what is meant when we speak about social policy or any of these terms, and often these terms are being used interchangeably and so on. So I was really interested and keen to uncover who means what when they refer to social policy, and also what does it mean to different people, to different organizations. Generally, I think from having looked at the literature, and again, Makanda has written a lot about the scope of social policy and how it's changed over time. It really seems that there has been an overall trend towards promoting universalism in social policy, at least in terms of rhetoric. So we would have education for all, universal health coverage, access to housing as a human right. So all these things, at least in the discourse, are quite prominent these days. But yeah, if you look close at the literature, you have people like Thandika Makandawiri, Adesina, Lavinas, who have really kind of highlighted. But what we're confronted in reality, in practice, is some sort of narrowing scope of social policy. So very often we don't have welfare state, comprehensive welfare states, as we would have seen in the post-Second World War period in the European countries, but also loads of these very expansive social policies in the African context after independence. But we would see the promotion of conditional cash transfer programs or quite targeted social protection schemes. So really, that was my entire motivation to go into my PhD, and that also, that's kind of what frames the paper that I've written. Maybe just one note: if we look into the literature on social policy, we would see quite a lot of theories discussing determinants and factors that have driven welfare state expansion and retrenchment in the European context, but actually, again, scholars like Makandawiri have really highlighted the importance to look at the African experience or developing countries' experience more particularly because we need to take into account colonial legacy, other global structures, imperialism, nation building efforts after independence. So all these factors really also define and shape social policy in an African context. I'm focusing in my PhD and also in this paper on health, and as I feel this is really an area where we see this push in rhetoric for universal health coverage, but actually the practice is quite something we need to pay attention to because universal health coverage can take different forms. And my focus is on Nigeria because it's close to home, but also really because Nigeria is an interesting case study. It is one of the countries on the African continent that has one of the worst performing healthcare systems in the world. In my paper, I'm referring to the 2000 World Health Organization report because it's the most very comprehensive exercise which has taken place analyzing the performance of healthcare systems, also looking at health inequity as it really also focuses on financial risk protection. And Nigeria ranked really poorly in that report amongst one of the 4 worst performing countries. Other countries, post-conflict countries. So really, Nigeria is really doing not so well. There have more recent exercises have taken place. Also, Nigeria not doing too well. But again, I'm really referring to this report because it put emphasis on this financial risk protection element. And if we look at some of the data, and I'm not going to spend too much time here, but it's what we see in the Nigerian context is that we see households, individuals being made responsible for catering for their own healthcare. So more than 75% of total health expenditure are really borne by households, by individuals, and public healthcare funding is really low. Many of you might be aware there's the Abuja target of 50% budgetary allocation to the healthcare sector, which was agreed on by African states in 2000. But Nigeria is really underperforming amount, allocating a really small amount, 4.6 in 2017, of its budget to the healthcare system. As a direct consequence, leaving aside all the other structural factors, obviously, that we would see in Nigeria that further social inequality, but we do see that the healthcare system is contributing to poor health outcomes. And Nigeria, again, is not performing well. 1 in 10 children die before they reach age 5, high maternal mortality rate. And again, I've also looked at these numbers really in African comparison, and we see that Nigeria is not doing so well. And one last point really I want to make is in terms of health inequity. It's not only about poor health outcomes, it's also really that we would see, especially children, mothers, of families of a lower socioeconomic background having worse outcome, right? And we see also like a geographical divide in the Nigerian case, where you would have like really poor northern states, which is directly correlated also with higher child mortality rates and so on, and like better for performing southern states. Maybe one word on the healthcare system per se. This is not really like at the center of this paper, but what we then see is like some of the reasons for that are really that the primary healthcare infrastructure, that primary healthcare system. So like the first tier of like provision of healthcare services, often preventative services such as immunization and so on, is really poor. And also during like the interviews and focus group discussions I've conducted in Nigeria, these things were always being brought forward. We were talking about like there is no water, no electricity in healthcare facilities and so on. Which then often meant that the private sector really stepped in and like provided some of these services. Many Nigerians do seek healthcare in the private sector, fly abroad, or like seek healthcare in the private sector within the country. And again, the private sector itself is quite is not homogeneous, and you would see like really high quality providers if you go to Lagos, but then also you have loads of like private patent medicine vendors and also lower quality healthcare providers in other parts of the country. So against this background, then like the enactment of the National Health Act in 2014 seems like a really encouraging milestone. So in 2014, you had like the president at the time, Goodluck, going on stage, committing that the federal government of Nigeria is keen to attain universal health coverage, making healthcare accessible to all Nigerians and making sure that they can actually access healthcare without suffering of financial hardship. There was a UHC summit organized in Nigeria in October 2014. And really following this summit, we would then have the adoption of the National Health Act a few months later in December. And really just on a side note, again, to show also the complexity of health policymaking and drivers, and I'm quoting Robert Yates here, the enactment or the adoption of the National Health Act just happened a few months before the 2015 presidential elections. So very often it might also be a motivation for like high-level politicians to drive such like reforms in view of like the elections and like them hoping to winning elections. One word on the National Health Act, as I will pick up on that a little bit later when I talk about actually the development of the National Health Act, but it was then adopted in October, signed into law formally a few months later. And it is actually the first legal framework for the healthcare system in Nigeria. It was many people pursued to have like a first law for the healthcare sector, really to ensure higher levels of accountability and making sure that actually it is being seen as a responsibility of the government to assure that people in Nigeria can actually have their rights to health respected. The act is rather comprehensive, several components, but one article really received much attention, which is the article on the Basic Healthcare Provision Fund, which is a new funding mechanism, really, which is being mandated by this act and put into place to provide more funding to the healthcare system, and especially the primary healthcare system. And it's quite novel, as I've shown you before, like public funding to the healthcare system is low in Nigeria. And now we see like this act putting into place a new funding mechanism, which like really is requiring the federal government to earmark some of its budgets to healthcare. So as per the law, every year, the federal government is supposed to make a 1% allocation, 1% of its budget allocation to the Basic Healthcare Provision Fund. The act was signed into law in 2014. The first allocation only happened in 2018. So actually a few years where, well, the federal government would have not been observing a legal framework. Disbursement happened only later, even in September. And then over COVID, some of the disbursement stalled. The first appropriation to the Basic Healthcare Provision Fund was around 150 million, just for your information. Nigeria is a country of 200 million people or more. So again, we just see also like by design already there are some limitations to what this fund can do. It encourages funding also from other sources. Some donors have put money into it, and also states. Nigeria is organized as a federation, so you would have the federal government, you would have state government, and you would have local governments, and also states and local governments are expected to put some money into this. The fund really is there to, like, on the one side, provide some form of social insurance. As I said, financial risk protection is really bad in Nigeria. You would have like households needing to pay for healthcare out of their pockets. So one of the aims of the fund was to like make sure there is money available for like social insurance and the provision of a basic package of healthcare services. But also quite a bulk of money goes into like strengthening the infrastructure of the primary healthcare system. A small amount of money is then reserved for emergency medical treatment, and I'll get back to that in a second. So we really have like a law now that's like designed with the ambition of like fast tracking universal health coverage in Nigeria. But the question now really remains, and again, like thinking back about like different perceptions of what social policy is and like what universalism could mean, what form can universal health coverage actually take in Nigeria in reality? What can we see? And so that's really the core of this paper. And I've looked into the process that has led to the adoption of the National Health Act, really in light of better understanding what kind of country-specific factors and setups, and I've mentioned Nigeria as a federation, but also global processes, a shift in like rhetoric around social policy and social policy practice. We have the ascendancy of neoliberalism in the 1980s. So how do all these factors and like the role of different agents within Nigeria influence the form that universal health coverage can actually take in Nigeria? And how did all these factors influence the law that's supposed to guide the process of like attaining universal health coverage in Nigeria? I'm not going to say much about it, but I draw on a political economy framework called the systems of provision approach, which really allows me to pay attention to like the interplay of different like interest group agents, structures, and so on. And I've mentioned before, I've conducted fieldwork in Nigeria and was really able to like speak to several people who are involved in health policymaking in Nigeria. I conducted focus group discussions, which was really informative for this work. So the main bulk of my chapter then concentrates on this trajectory of health policymaking in Nigeria, and I've broken it down in 3 episodes. I want to briefly say a few words around like health policy making, if that's what you would want to call it, during colonial rule, but also then especially during the first 2 decades after Nigeria's independence in 1960. Then a second period where we would have like neoliberal policy making, which definitely did influence like health policy making in Nigeria concretely in the 1980s. Which also coincided with like economic crisis in the Nigerian context specifically. And then like brought this satisfaction with like the structural adjustment programs also in Nigeria, and calls for an adjustment with the human face from, let's say, the 1990s onwards, end of 1980s, which again influenced health policy and the conceptions and like thinking about health policy in Nigeria. So the first period, I'm calling it pre-post-colonial period, quite broad, but we would see like manifold transformations. So obviously also before like European settlers arrived like in Nigeria, there were like some forms of medicine being practiced. They were quite pushed to the margins with the arrival of like European settlers, missionary church. And so there was then an introduction of, if you want to call, modern medical services throughout that time. But actually, the British colonial power government did not pay much attention to like the healthcare needs of the general population. And I really do think, and again, I'm making reference to Thandika Makandawere's work, that colonialism is one of the important variables that can help us understand and explain certain social policy trajectories. And in the Nigerian context, we had the British colonial power trying to like continue pursuing its like self-interested economic policies, while at the same time kind of making some concessions in terms of like welfare to the general populations. And I have just one quote where I'm already showing that like already during that time, you would have these discussions around what welfare policy should entail, what comes first. Is it welfare, is it development, economic development, and so on. And importantly, also really I think that's also important for Nigeria going forward, is like going back and looking at some of the policies which were being implemented already during that period by the regional governments. So Nigeria at the time, from the 1940s onwards, was divided into regions, and you would have, like, I'm giving an example, the Western region of the 1950s, led by the Action Group, who were really putting an emphasis on making sure that there is access to free healthcare and education for the general population, again, with the aim in mind of like investing in citizens, and like this being an important part of actually developing the country. So this intensified after independence in 1960, and also is follows the spirit of the time, I'd say. You would have the Bandung Conference in 1955, followed on then by the establishment of UNCTAD, and really the focus of the time was more so that like access to social services and development and integration of these newly independent nations needs to happen within like a context of a fairer international economic order. Social policy, as I was saying, was really not only seen as like a means of keeping the working class like silent and like at peace, but also really as a nation building instrument, trying to like further social cohesion, building like nations. And again, Thandika's work on that is really inspiring. So what we then see in the Nigerian context concretely is really, even after independence, the British depart, but we would see that Nigeria, having discovered oil in the 1950s, 1960s, starting exploration, is using these funds to actually fund universal and free healthcare in public facilities. Interestingly, though, in the Nigerian context specifically, and that might be different in other places, is really that already in the 1960s, we would see some sort of private sector lobby kind of taking influence over policymaking. So in the 1960s, in 1962, there was a proposition to introduce some form of national health insurance scheme to the country, but that kind of like was pushed back by mainly private practitioners in Lagos that formed part of this Nigeria Medical Association. So the bill was rejected at the time. But still, there were like policies that were part of the national development plans, which did like focus to some extent to like increasing the standard of living of the general population. And then especially the third national development plan, which was introduced after like a civil war, which was fought at the end of the 1960s. And like we would have the onset of the military regime, the first military junta in Nigeria as well. But the third plan really tries to put like a basic health service scheme at its center. So also again, like with the idea of having some form of redistribution. But then, and I don't think I have to say much about it, we've also heard like a lot about like the structural adjustment programs in the last 2 days. You have the onset of neoliberalism. We have like a rhetoric, and I'm thinking, for example, about the 1981 World Bank Berg report, which would argue that like bad governance, corruption, clientelism within African countries is responsible for bad economic performance. You really have a discourse of like welfare state crisis. You have the Washington Consensus becoming mainstream. So you really have like this whole set of neoliberal ideas which like takes center stage in like policy making. And in direct consequence, in healthcare systems, not only in Nigeria, but in actually quite many of the developing countries, you would see a trend towards criminalization and privatization of healthcare service provision. And that's really when you also see like a reduction in public spending to the healthcare system, and like the importance of like the introduction of user fee and the importance of out-of-pocket payments going up. Concretely, in the Nigerian context, it's not only this like ascendancy of neoliberalism or like this emergence of like neoliberal ideas, but you also have like the oil price, or the global oil price declining, which again like then resulted in Nigeria in like a reduction in like public revenue, and you would have really this economic crisis unfolding as a consequence. So really. Just a note, in the Nigerian context, you would see like these two things coinciding. On the one hand, like a reduction in revenue just as a result of the declining oil price, but then also like this whole new ideas neoliberalism and neoliberal policies like taking center stage. So the last period I just want to like say a few words about is then like what happens like from the 1990s onward. or like even the end of the 1980s, because still in the Nigerian context, we would see some kind of progress in health policy making, very much like you can very much associate it with like some leading figures, like some quite charismatic figures. So Ransom Ekuti comes to mind, who was the Minister of Health at the time, who really pushed forward this whole idea of like concentrating on primary healthcare as one of the pillars of a healthcare system. And you have the adoption of a health policy in 1988, and then the establishment even of a national primary healthcare development agency a few years later. So again, this coincided with like general discontent of the population and like people with like the structural adjustment programs. But still, at the time, there was not much political impetus. You would still like being like during the military regime, and also the economic situation wasn't great. So none of these propositions, like the proposition to introduce a national health insurance scheme at the time, actually materialized. Interestingly, though, in 1995, you would really see like the Abacha regime, military regime is in power at this time, like kind of like trying to reconvene different stakeholders in the healthcare system, and then really with the aim of building more consensus around what the role of the private sector should be in Nigeria's healthcare system. And I think this is decisive then now going forward, discussing the National Health Act in particular and like what it can do in terms of like helping us fast track the goal of like universal health coverage. Because when the National Health Insurance Scheme was actually signed into law in Nigeria in 1999, you would see that the private sector really featured prominently. So on the one hand, like private sector providers were basically invited into the scheme. But on the other hand, you would also have like this private, mainly for-profit health maintenance organizations who would act as intermediaries, meaning they would do the enrollment on behalf of the government and then like connect the people that they have enrolled with often private providers. HMOs at the same time are then allowed to offer their own private health insurance plans. And again, that like creates problems. That means like many of the private sector companies might not be compelled to actually go contribute to a big social health insurance pot when they can go and pursue private health insurance plans in parallel. So really the setup kind of was faulty. And I think this is being discussed, or there's a lot of literature on that as well. Especially also because this social health insurance scheme was made voluntary, again, on the initiative of private sector interest, so that actually the formal sector has an alternative. I'm just citing Chima Onoka here, who's really then saying, like, we see that these private sector actors who have been influential throughout this process can now also continue influencing policies and outcomes of really this universal health coverage reform in their favor, because they're so well positioned and we have such a dominant private sector already in Nigeria. So in terms of National Health Act now, so now we arrive in the 2000s, all right? And like we have this report that I had mentioned before being published, showing that like, well, Nigeria is really performing badly and the health outcomes are bad, the healthcare system is underperforming. Already at that time, there were like like-minded Nigerians who then came together to say like, no, we need to do something about this. So from quite early on, 2014 is when the act was actually adopted, but already in 2000, these discussions started saying like, we do need a law that's better at governing the healthcare system. Because at the time, it was really just the constitution that was supposedly providing some kind of structure to the healthcare system, but which it wasn't doing properly. So you would have like a change agents program being called into life, and I'm mentioning Professor Lambo here, who was like a WHO consultant, but quite again like an important figure. And again, like sometimes really these leading figures who come in with a certain set of ideas and trying to like mobilize people around this whole idea of like driving a health sector reform in the country. And so people from different backgrounds came together to really found this change agents program and like come up with a diagnostic of the healthcare system in Nigeria. What is wrong with it? What needs improvement? They organized missions to like Ghana, South Africa to really understand what is the shortcoming that we would see in Nigeria. So I was able to speak to some of the former change agents during my field work, and there was one who said like really we went on these missions and we came back to Nigeria and we were really ashamed of ourselves, seeing like how little progress Nigeria has made over these decades. The change agents programs then kind of was faded out in 2004, 2005, and the NGO or the civil society organization Health Reform Foundation of Nigeria kind of took over its role. Around that time in 2003, Professor Lamba had also become the Minister of Health, and he formally initiated a health sector reform program. So there was really some momentum and push to like now try and get a law developed for the healthcare system. But one of the main arguments I was trying to make in this paper is really showcasing how like complex health policy making or social policy making more generally is, and like how different like country and system specific factors can influence a healthcare system reform. And for example, you would see that like a first draft of this health bill was already tabled in 2005, and you would have like buy-in by the National Council on Health, which is the highest maybe policy making organ or decision making organ in Nigeria on matters of health, where you would have the federal ministry convening with like the state commissioners on health, so a quite high level forum. And like the bill would have been accepted there, but then later on states like use different channels to intervene and show their opposition to the bill, and really intervened in a way that like pushed back or like delayed actually attempts to make like the bill a law, to like get it signed into a law. I'm just mentioning a few other milestones, so I've like detailed them out in the paper, but like you would see then that one version of the bill would be passed in the House of Representatives, but would then fail passage in the Senate. Then like you would have both like chambers of the National Assembly working on drafts. Then there was a problem with the wording, and so on. And interestingly, you would also see other agents, interest groups within the country really trying and succeeding at like taking influence on like this whole policymaking process. I'm mentioning some of the religious groups, for example, the Catholic Church, like being wondering if there's something on abortion in the law, or if there's something about blood tissue and like cloning in the law. So there were several issues that like really were important to certain groups, and they like used their power and position within the country to like influence the health policy making. One point is also the role that the Minister of Finance was playing at the time, because as I mentioned before, one of the key features of the National Health Act was really that it mandated the establishment of this fund, this novel health financing mechanism. So the Minister of Finance was kind of wary of what that would mean in terms of finances for the country. And I'll pick that up in a second. But one important point really is also that like during this time, we would see really a strong civil society that would be trying to convince Muslim communities, Catholic Church, organizing presentations, developing advocacy material, trying to get on board like key figures in the healthcare, in the global public health sphere, to actually gain the support, especially also of the presidents, to get this bill signed into a law. And yeah, they organized also like grassroots movements, organized like a women's march to the National Assembly, which really, this was in 2011, which really then like helped and like supported the whole process of getting the National Health Bill then signed into the National Health Act. So these are my last few slides. What I then really want to say is like, this whole process and like knowing what has happened since the 1930s onwards, the role of the private sector, the importance of like different key figures and so on, has influenced policy. And like influence on policy means also influence on the form and shape that universal health coverage can now take in Nigeria. And I'm mentioning just a few. For example, this basic healthcare provision fund was at first supposed to be really a fund only for primary healthcare. So now I've said that there's a component going to emergency medical services. This was not supposed to be the case. The focus was really that it was supposed to fund public primary healthcare facilities and enabling them with providing better services. I've mentioned the Minister of Finance, who was like pushing back and really also in first drafts of the National Health Bill. And I mean, these drafts are available. So you would see like what they had proposed in 2004, like the changes, and like you can compare with the final text now. You would see that there was a proposition in there to actually make it a 2% annual allocation from federal budgets. And now we only see a 1% annual allocation. And again, it's 150 million in 2018. Now it's even less because of like a decrease in revenues. So the budget being less. So it's really little money. And obviously that has implications of who can actually access healthcare, how much healthcare can actually be provided using like this extra funding. And interestingly, again, the Minister of Finance reluctance to have like a 2% allocation to like the basic health provision fund stemmed from a bad experience of another sector, the education sector, where we would have seen like such an earmarked funding of 2% not being used, right? Because states would have needed to provide counterpart funding. Many states might have not been able in a position to do so, might have not had the interest to do so, which meant that the money was like just a treasury. Because it was a statutory allocation, so that's a kind of like earmarked funding, which which cannot be used for different purposes. Just to highlight like how different political economy elements actually shape policy. I've mentioned the role of the states and the opposition from states. Again, in the final text, we see that everything that would have clearly said what the responsibility of states should have been was basically taken out. And we have the introduction of emergency funding. Again, from what I've gathered in like the interviews and like the discussions that I've had with many of the people who were involved in this process, this was just, again, like the motivation of the federal Ministry of Health to also capture, like have like responsibility for like some part of this funding and not only have other agencies administer this money. And lastly, we would also just see in the policy per se, in the act, if you read it, that like private sector involvement continues to be maintained, encouraged, which then translates directly into like a quite widespread discourse, although it's quite nuanced, that like the government on its own cannot provide access to healthcare services for all Nigerians. We do need the private sector in some form. And to a certain extent, this might be true or this might be not incorrect, let me say, because a lot of the insurance knowledge in terms of doing the enrollment, claims management might lie with these health maintenance organizations, which have been doing this job for quite a while. So now that the questions arise, to what extent can state health insurance schemes take over? So two more minutes really just to like kind of summarize what it is that I was trying to argue in this paper. One point is really like, I wasn't concentrating on like discussing the many implementation challenges in terms of like the problems that we see in the primary healthcare delivery system, but it's more like to like highlight that like all these challenges and how the policy deems to address these challenges actually do shape the form UHC, universal health coverage, is taking in the country. And as mentioned, if the money is little, well, then we might need to target. And that's what we actually now see. So other chapters of my PhD concentrate on now on the implementation issue, where you would really see that like now only like children under age 5 and women of pregnant women of certain regions that have a certain poverty incidence are now allowed to actually access this basic minimum healthcare package. So that requires some form of targeting, and that again like ties into the whole discourse of like having a targeted social protection intervention rather than a universal social policy for everyone. And really, it also shows just the complexity and the importance of the political economy when we talk about policy making. We had a quite active civil society that was driving the process, but you then have also quite important resistance from like state commissioners who are quite powerful. At the same time, you might have like a federal minister of health who might not be as powerful during a certain period of time. So all these things matter when we look into policy making. Concretely, I think three factors stand out if we look into like how all these agents were involved in policy making, which is really that we would have had the strong private sector lobby from the 1960s onwards, then obviously reinforced also by a global discourse of like privatization during the 1980s. But this is obviously like now continuing to influence like the actual practice of healthcare delivery in Nigeria. And like also the role that the private sector is supposed to play in attaining, or like in efforts to attain like UHC in Nigeria at the moment. And other important country-specific factors, as you may say, is like that Nigeria is organized as a federation. So you always see at different levels, and again, this plays out especially in policy implementation, but like states wanting to like domesticate federal laws and not necessarily taking everything the federal level says for granted, and like trying to like incorporate it into their like state level context. And the third really takeaway is that like you would see also during focus group discussions that became quite clear, you would have again general distrust that actually the government is apt to provide universal health coverage to all Nigerians. And that's the last slide, really, to say that like all of this like really plays out in like this broad shift of within social policy. There's a certain distinct set of ideas, if we talk about universal health coverage, that is being basically implemented and promoted at the time. And it's very different to like the ideas around primary healthcare for all that would have had center stage in the 1970s, especially. So really to go around the circle, it's really what we've seen is like that the scope of social policy also in the area of health is continuing to narrow, and the policy practice is playing out to be like a targeted and very small package of healthcare services, and not like healthcare for all and everyone, and like without financial contribution. But actually we do see that like there is always this contestation and like conflict between like on the one side like this neoliberal idea and then like proponents and advocates for a much more solidarity based real universalism that is then shaping like actually social policy outcomes. Yeah, thank you. This is it from me. Thank you so much.
Thanks very much, Julia. That's a fantastic, rich presentation. Thank you.
Thank you.
It makes me think very much of, I was interested in what you said about the teams from Nigeria going to look at what was going on in South Africa and other places. I mean, I think that the South African situation is one that immediately comes to mind with some of the problems that you're raising. So I'm sure that you're going forward, the kind of political economy analysis with respect to the implementation is going to be very, very interesting. And what I should have said at the beginning was that prior to Julia's studies in London at SOAS, she was also with UNICEF's social policy teams in Burundi, Mali, and Senegal. Now that must have given you some extremely interesting insights as well. And perhaps we can hear something about that in the discussion. All right. I'd just briefly like to introduce Dr. Mann. She's an assistant professor at the International Development Department at the London School of Economics and Political Science. Laura's a sociologist whose research focuses on the political economy of knowledge and technology within the global economy. And we look forward to hearing your contribution, Laura. Thank you.
Thank you very much. So I wanted to start off just to congratulate Julia on the paper and the prize. I was one of the judges in the first stage, and there were two stages. And I can say among the first stage, it was like a favorite of everyone, and it wasn't a difficult decision. But then it went on to a second round, and they obviously had the same opinion. So yeah, it's very well deserved, and a big congratulations. And I'm really hoping to kind of see this in the published form. I'm hoping to cite it and put it on my reading list. And I'm excited to see your other chapters. And yeah, it's very exciting to see your work come out. So I thought I would kind of structure my comments about the paper in light that it's the Thandika Mkandawire Prize around some of Thandika's key contributions, how your paper connects with them. And I'm then going to sort of make some suggestions along the way of like how the paper can build on those legacies and also kind of make a bigger kind of impact in terms of like the theoretical contributions. Because I thought the description was very, very rich, but I think you need to be more ambitious in like being more explicit about what are the contributions to kind of wider debates within the literature. Okay, so first of all, and you kind of mentioned some of the things that I'm going to say, that, you know, through Thandika's directorship at UNRIST and through his works and with his collaboration with Jimmy Adesina as well, he played a very important role in the kind of pushback against this idea that social policy is a residual or palliative thing, only addressed at poverty reduction and targeting towards the very poor. And as you say, you know, he talked about social policy having a more transformative role, being about protection, redistribution, reproduction, production, and nation building. And he stressed that when it came to developing countries, the kind of production and nation building were kind of some of the really important roles that social policy could play. And those are the two that kind of get neglected within kind of donor visions of social policy. So he was very keen on kind of stressing the productive role that social policy could play, thinking about how it interacts with kind of human capital formation, thinking about land reform as a kind of social policy, and thinking about how kind of social policy instruments like pensions could be used for mobilizing financial resources, and like marketing boards and subsidies having both economic and social kind of policy implications. And then secondly, as you said, he also thought about social policy in terms of social cohesion and nation building. And I think this is where your paper really kind of connects with Thandika's work. Another thing that Thandika, kind of a point that he often made, was to kind of contrast the kind of fact that donors want to fund social policy aimed at the very poorest, because taxpayers in high income countries, you know, they want their tax dollars going to the very poorest. They don't want to be subsidizing kind of middle class people. Whereas for domestic governments, they need to have middle class voters on board, right? So they want social policy that has a kind of broad social base, both in terms of kind of creating social cohesion, not stigmatizing, thinking about social policy just for the poor, but also for the practical reasons that they want people to want to pay taxes to social policy. And finally, Thandika talked about the fact that structural adjustment had created this context of kind of choiceless democracy, in which donor influence meant it was very difficult for domestic politicians and policymakers to really develop policies that kind of resonated with the public aspirations and public visions, political visions. And connected to that point, he was always very critical of kind of scholarship of African politics, particularly by non-Africans, that kind of thought about politics in this very dry, kind of quantitative way that didn't take seriously kind of ideas and ideologies. And I think there's a kind of connection between choiceless democracies and this kind of theorization of African politics. So one of the things that was really lovely about this paper was the kind of focus on kind of domestic contestation. You know, it wasn't a kind of rosy picture of kind of domestic actors fighting against external pressures. The agency was about domestic actors and the kind of domestic drivers, domestic visions, and kind of conflicts within civil society, within the private sector. And so that was really interesting, and I think it's really an important kind of contribution to make. And indeed, one of Julia's core insights was the fact that you have this very fragmented policy landscape from this history, and that makes it very difficult for policymakers to kind of reconcile these competing visions and interests, so that kind of what universal means at the end of the day is this very narrow vision rather than something that has a kind of wider sort of political, lives up to kind of aspirations and ideals. So one of the things that I wanted to kind of probe Julia a little bit more on and get some clarification was that the kind of argument leaned heavily on this kind of idea of neoliberalism. And there was kind of a three-part argument about the role of the private sector, neoliberalism, and then regional kind of contestation. And I wanted her to be a bit more explicit about the links between these. And sometimes when you were talking about neoliberalism, you kind of were talking about it in the passive voice, the ascendancy of neoliberalism, the spread of neoliberalism, or neoliberal reforms were kind of introduced. And I think this is pretty common when people talk about neoliberalism. It's kind of this force that comes in from outside and reshapes everything. And I think what's really kind of interesting and exciting about your paper is that you're showing these kind of domestically rooted political processes that are already existing and how they're kind of interacting with neoliberalism. And I think it would be nice to be a bit more explicit about that. And to kind of, instead of talking about neoliberalism in the abstract, talking about what is the interaction here between neoliberalism and these various domestic interests. So for example, how did the private sector actors actually interact with these pressures? And you've talked about lobbying a little bit more, but it would be nice to be even more explicit, you know, like how strategic were they? Also, when it came to regional politicians and their political visions and strategies, how did they kind of see neoliberalism as a kind of opportunity or barrier to their own kind of political ambitions and strategies? How did domestic civil society groups, so the kind of Catholic Church and the Muslim organizations, also kind of play a role and actually interact with neoliberalism and kind of popular beliefs about the role of the private sector? And how did private actors kind of interact with these faith groups and with regional kind of political conflicts as well? So I would really kind of encourage you to talk less about neoliberalism as this kind of impersonal force and talk more concretely about the interaction of domestic interest groups, faith groups, and kind of, you know, the rise and spread of neoliberalism as something that's more domestically rooted. And I think this also connects to this idea of kind of the choicelessness within democracy. So they kind of contend that these entrenched interests make it hard for universal coverage to kind of live up to that political vision, so it becomes reductive. In Thandika's work, he rooted kind of choicelessness and the kind of narrowness of policy space in terms of direct donor control over policymaking during structural adjustment. But I think you kind of have an interesting argument here about how it's not just kind of immediate power of donors, but the kind of entrenchment of the private sector and federalism and the kind of ruptures that happen during structural adjustment that have these kind of knock-on effects where you have domestic actors actively wanting to try to maintain a kind of narrow room of a remover. And this kind of reminds me when Thandika used to teach, he often had this very long-term chart about just the rise, fall, and return of growth in African economies from the 50s onwards. And he would always have this kind of periodization of economic history to make people kind of aware of, whenever we were talking about something, how it was kind of rooted within this long economic history. And one of the things that he made clear is that when you kind of have the resurgence of growth, it's not like a pendulum where, you know, growth returns and people have autonomy, you know, policymakers have autonomy, that in that dip, the landscape has been transformed. So growth doesn't mean policy space and autonomy anymore. And I think in this paper, you're kind of talking about these structural shifts, and it would be interesting to be a bit more kind of explicit and maybe have a bit of your own theorization here, kind of maybe taking that Ben Fine framework, which you don't use that much in the kind of empirical sections. And I'd kind of like you to have your own framework or to be more explicit about how you want to change it. And one of the kind of two things I thought you could kind of make a bit more material was being more explicit about the business models and the financial systems of the healthcare sector, and using these as a kind of skeleton to understand kind of the power in the context, and how does the kind of changing skeleton of the financial, you know, underpinnings of the health system, how does this kind of the Article 11 go up against these, kind of takes into account these or threatens people's interests, and kind of looking also at the kind of states and federal matching funds. So to kind of give the reader a bit more of a structure to understand how things have changed. So I think the kind of financial side and business models could allow you to do that. But I think it would also be interesting to think about it in terms of the kind of career structures, because you're talking about the private sector, and you're also talking about kind of in your presentation, you talked about kind of the knowledge transfer, the HMOs and third-party administrators. So kind of thinking about changing career structures at the heart of these systems over time. So if you can kind of trace from the 60s through structural adjustment to the present day, it would be like a very interesting kind of look at how, you know, what are the key structural shifts that are happening, you know. And the last thing that kind of connects to these kind of broader comments is a very sort of specific comment about the paper that I think you want to tighten the links between the historical section and the contemporary discussion of the fragmentation of politics a little bit more. That in the contemporary section, you mentioned kind of these interest groups, the rivalries within the healthcare system, kind of federalism, the kind of civil society, either opposition or support, this HEFON group and the change agents. I would like to see those kind of seeded a bit more in the earlier historical period. So instead of having like specific groups in different time periods and their specific names, kind of giving us a better sense of the kind of the social base of this kind of opposition or support and the kind of longer histories of them. So how do, you know, so we can get a better sense of like how different groups, is it the same sorts of groups that supported it in the earlier period, or are there new groups? So having a bit of a kind of tighter, some way of tightening the connections between the history and the contemporary section, I think would be really helpful. So I guess there's a lot to kind of give you, and I'm happy to also talk more and to share some written notes and comments as well. But yeah, I think it's a very interesting case. I think it's a really wonderful paper, and I'm very happy and excited to see what other things you also have up your sleeve. So congratulations again.
Thanks so much for that, Laura. That's absolutely fantastic feedback and input for Julia, particularly as I'm sure she wants to get this into journals in due course. So that's great, thanks. The other person who was terribly excited about Julia's prize was Ben Fine. I spoke to him on the email recently and he was completely delighted and said he was going to get in touch with you. Right, so I think what I'd like to do is maybe just give Julia a chance first to respond to those comments for, let's say, 5 minutes or so, and then we'll still have 25 minutes for discussion to open it up to the floor, if that's okay, Julia, if that suits you.
Great, thank you so much for these comments and for engaging so much with my paper. I really appreciate it. I've taken notes like a crazy person, so I'll be digesting over the next few days and weeks. Yeah, I've just picked up and like circled some of these that I really think are important, and like things that I think I should try and really make clearer, because they are key of what I think I would want to say, which is really this whole idea about ideas and ideology, and them like not being choiceless democracies. And absolutely, it's also true. Maybe I should like be clearer when I use like certain language. When I was speaking to people within the World Bank, these are Nigerians I was speaking with who are working with the World Bank. So it's not like some imposition, some people coming from Washington, DC, importing some of these ideas. And I was asking also a little bit broader, talking to people like working in the cash transfer office, and they were very clear in saying like, oh, this is something that we want. It's not the World Bank that came and said like, oh, you have to necessarily go and do a cash transfer scheme. So I do really very much think that like one of the points that is important to make is like some of these ideas are being discussed in the Nigerian way and by Nigerians, and they might have their own ideology, and their ideology might be rooted in like some form of first wave neoliberalism, but it's not that Nigerians are just like standing here waiting for like people from Washington DC coming to tell them what to do. So that was one point that I really think, yeah, is important, and maybe related to that. And yeah, that's maybe a point that I can try and make better in the paper, connecting these things. There is quite some bits and pieces that like try and describe how, like, for example, these health maintenance organizations are being pushed forward in Nigeria, which is kind of uncommon. Not many countries do have like this for-profit private entities kind of like administrating like public funds as part of a social health insurance schemes. And you can really again see, and maybe it's more like a class analysis, but you would see like some connection between like, I don't know, a capitalist elite, often like around like doctors being trained in the US, mainly in this concrete case, coming back and like promoting something that is beneficial to their interest in the end, right? I mean, if they are allowed, there's also, I mean, I'm not like talking about that in the paper, but I'm talking about that in my PhD. There is legislation saying like if you're a doctor employed by the government, that you shouldn't be like at the same time allowed to like offer your private services, but this is routinely being done in the Nigerian context. And there's also obviously controversy around like this decrees that were enacted and like repealed and so on. But yeah, I do think it's actually important. That's really good advice, that I try and like trace which kind of groups then connect to like the groups that are like driving a certain discourse and narrative nowadays, like in the process of like implementing universal health coverage in Nigeria. Maybe in terms of, yeah, career structure, that I felt is something that I definitely would want to look into more. Maybe some of the Nigerians here know more about it as well. Is really also like this ongoing conflict between, like, it seems the medical doctors as like the highest you can get within the healthcare system, and like all the other medical professions, which I think is particularly important if we talk about universal health coverage, because well, universal health coverage falls and stands with like primary healthcare, right? And so I think also, I mean, I have not mentioned that in the paper, but there was also like conflict on who is allowed to chair which committee. Does it have to be a medical doctor? What is the role of like other community health extension workers? What's the role of nurses? What's the role of other health professionals? So I think that's really important in terms of also looking at career structures. And then, as you were mentioning, also in the second, if we look into, I don't know, like the other administrative bits of like access to healthcare or guaranteeing access to healthcare, which is really this like concentration of like some of the insurance knowledge with health maintenance organizations, and how Nigerian, in this case, state governments go about it. Because now that I looked at in my chapter on like implementation, you would see some state governors and some state commissioners on health going and like actually using HMOs again to do parts of their health insurance business. And then you would have other states that like quite independently try and develop their own state health insurance boards that then administer enrollment and so on, and maybe recruiting some of these people from health maintenance organizations. But there is still a difference in terms of like where money flows to. So I really think that's important. In terms of regional leaders and like how they interact with neoliberalism, I think that's interesting. And I'm sure there are differences, I mean, not only between the North and the South, but also between like different states. And you would see, I mean, now that state governments are in the process of, let me say, are starting the process of implementing their own state health insurance schemes, which is the version that is now being proposed as part of the manual of how to implement the basic health provision fund, you would really see many of these differences materialize in some state governments reserving equity funding to say like, oh no, we're making this at least like categorical in terms of who we target. It's like, okay, if it's children under 5, fine, but let's make sure we don't do this means testing targeting, which is often, I mean, there's a lot of literature like really quite convincingly showing us that there might be exclusion and inclusion errors when we do this kind of targeting. So I think this is maybe this is something I would be interested in continuing doing my research, like looking at the differences between like the state governments, because we do see different speed and progress at which like states are kind of like now making use of like the funds, are putting their own funds towards like the goal of making healthcare accessible to all Nigerians. So also really, really helpful. Yeah. Thank you. I think this was 5 minutes, but I would love if we could talk more, and obviously I would appreciate any comments that you would have. So thanks so much.
Thanks very much, Julia. Right, so we have some time to take questions, and I'm sure there are. So I think that we'll take 3 questions if you'd like to direct them to, well, through me. That is Sand, I think. Would you like to go ahead, Sand? You just keep it brief.
Yes, thank you very much, Nikki. That was an excellent presentation, Julia. I'm so proud hearing your how detailed you went in to be able to get this to get a paper out, and I say congratulations to you. Thank you very much, Laura. I was wondering if Laura is a Nigerian, because the way she was asking you to put certain things in place, and it seems she knows more than we that are even here. But basically, my question is not a lot of questions, really. I was wondering, during the course of your research, although there are a lot of politics involved in, you've mentioned it, who leads the medical association, who becomes the Minister of Health is an important thing. It must be a medical doctor. There is this superiority of contest going on between the nurses, the denticians, the dentists, the medical profession. There's a lot of the consultant, a lot of the politics that is going on within. So what my question is, especially the HMOs, I realize that most times they are very influential. Now, before now, no one knows them, but it's like banks have gone into it. So it's 2 questions I have. One, when you were doing your study, what was the interest of the people that promoted this HMO? We were able to find out what was their original interest. Is it to offer a broad or comprehensive healthcare insurance to Nigerians, or to use as a means to profit themselves? What I mean is this: we realize that banks have gone into it. Some insurance companies have gone into it. Was it the initial thought, or it was just to offer healthcare system to Nigerians? Up to these days, you go to the hospital to tell you your coverage does not cover XYZ, but you say, but it's the contract it has. There's no way you can go to contest this. My second question is this: currently there is this mass migration of doctors leaving the country. Do you think this is a good thing? Some people have said no, it's service exports. Now Nigeria is going to get return from it. Some people feel it's brain drain. Some people feel, because currently they're on strike. I don't know if you're aware of it. They're on strike, and we have our president going outside. That is a different ball game, though. So I just want to ask just 2 questions. One is the initial idea behind the HMO, is it for universal healthcare, or it was originally targeted just for profit alone? Secondly, within the current movement of doctors out of the country, is it a good thing for us, or is it a bad thing? Thank you.
Sam. I'd like to abuse my position, if I may, and ask another question. I know that you've got a lot on your plate with looking at the different levels within the country and so on and so forth. Have you done anything comparative with respect to other countries? And I'm thinking again, my particular interest is in the South African case, where we are trying to move towards our NHI. And as a corollary of that, has the pandemic lent impetus to plans for a proper universal coverage? It seems to have kickstarted some things here anyway, but I know there's still a lot of issues. Okay, so that's the second one. And then the third one, Opeyemi, please go ahead.
Hi, good afternoon. Thank you very much, Julia, for that amazing presentation. I also enjoyed the input from Laura, learned a lot. It was like a lecture entirely. Thank you very much for that. I think I really don't have much comment, but to really appreciate you for the presentation, and also to just share your thoughts. And maybe Laura could also add a few things here if we have time for that. Since it seems you have very good knowledge about political economic dynamics of policy contest. I'm an economist, development economist, but then I'm also at a phase where I find myself doing a number of work in the area of political economy, but then in the energy sector, that's looking at the political economy around shifts, basically, like introducing market-based instruments to to encourage shifts in behavior. So you want people to be recycling, you want industries to be using low carbon technologies and things like this. And there's a political element to it, because in economics, we believe that politics has influence on economic outcomes and economic policy. So if you don't understand how the political environment works, which I think is one of the things that Julia showed us today, you'll just find out that policies will end up in paper and implementation becomes a different ballgame. You begin to have resistance. So my work had been looking at the political economy of phasing out forced subsidy. Okay, that's the context of my own work, why you are looking at healthcare. So I'm just interested in knowing some of the things that helped you in the people. I heard you saying you spoke to some people, had some interviews. What were some of the things that you can say helped you in capturing the feedback from the political environment that might be helpful to some of us working around that area of research? If you could just share some of those, so because a lot of times you have resistance from them having to speak on some of the sensitive issues. Thank you very much.
Thanks a lot. Right, over to you, Julia.
Thanks very much, and really thanks for the questions and for the comments. I really appreciate it. Yeah, maybe Sand, you asked why the HMOs, why were they introduced, so like why were they put into place in the first place? And really, through some of the interviews, and some of the interviewees were quite clear, saying like when like they came up in the 1990s, they weren't all bad. So you had like a few HMOs who started business, really like concentrating on like an important component of like the health insurance business. The first propositions, like if you look into blueprints of the social health insurance scheme, like wanted state health boards or state health insurance boards to take this role on, right? It's like having like public entities like actually doing like enrollment, claims management, and so on. But then there was like this I mean, in literature, it seems like there was this quite like strong-ish pro-sector private lobby from the US who had like seen health maintenance organizations in operation in the US, who then came and proposed this. But at the time, there was also a little bit more control. But from what I've understood, there is quite widespread consensus now that like actually HMOs, or these health maintenance organizations, do not have any value added. And if you look at the text of the National Health Act, they are not in there. And then there were different iterations also of the implementation guidelines of this basic healthcare provision fund, so the fund that's trying to implement the social health insurance schemes. And like a first version didn't mention HMOs at all. A second version mentions third-party administrators. If I then spoke to many of the people, who do you mean by third-party administrators? And they were pointing me back to the HMOs. But now a new version of guidelines was only like adopted end of 2020. And again, health maintenance organizations are not supposed to like play any role in like this national health insurance scheme or like in the social health insurance scheme. But again, political economy, some states still feel maybe the need to like draw on health maintenance organizations for components of the health insurance business, and others might not. And really what we've seen, and you've mentioned that, like, and this was again mentioned a lot during the interviews, it's like everybody went now into this HMO business. The introduction of this, like, or the kickstart of the social health insurance scheme was really good for HMOs, and every bank, every politician wanted to have like a HMO at the site, because it was like kind of guaranteed public money, right? It was really like every month, like a capitation or monthly payment made to an HMO. And speaking to both private and public providers, then you would say, they also would say like, you know, the doctors are now doing the work even within the private sector, but like we actually don't get back any money from the HMOs. You've mentioned this, right? Like sometimes you go and say like, oh, actually my insurance card says I'm supposed to get this service. But providers are like, yeah, I know you should, but I know that I won't be getting the money back, so I'm not going to offer the service. One point only, just out because I think it's interesting, we also would see like the IFC, so the World Bank Group, continuing to like 2016, as recent as 2016, providing funding to like some of the HMOs in Nigeria. So this is still an interesting point, although there seems to be quite a consensus within Nigeria with most of the Nigerians I've spoken to within government and so on, that we don't need HMOs. There is like some funding going towards HMOs. So this is definitely something I should be looking more into as well. Second question, mass migration of doctors to the US, the UK, and so on, brain drain, strikes within Nigeria. I mean, I don't think it's a good thing for the country, right? If you, and some of the interviewees, or many actually of the interviews were highlighting this, you would see like an emergence of like teaching hospitals in the 1950s, well, in the 1960s, 1970s. So many of the states had like their own teaching hospitals, and the doctors were being trained and like stayed within Nigeria. But then you have like this massive like underspending of the public health infrastructure, which often means even if you're a trained doctor and if you're trained within Nigeria, you would want to go and practice abroad because there is no electricity. It's really that basic. There is no electricity, there is no water, let alone the medical equipment to actually do a good job. So to also not like kind of forget all the skills that you have acquired, but also to like be able to perform your duty. I think like many doctors go abroad, and it would be great if we would like go back and again look into what like governments might have done in the 1950s, if you look at the Western region, but like also the federal government of Nigeria in the 1970s in particular, to actually make use of some of these medical doctors and like also other health workers, right? Because well, we also need like many of the other health professionals to like make sure that we can guarantee access to healthcare. Nikki, your question, if I've looked in detail at other countries, including South Africa, I mean, I haven't really. So I haven't done any comparable analysis of like any other countries. And I know little about South Africa. I mean, I've looked into, there are like several scholars who try and compare different African systems and try and classify them in certain ways, and like their way of going about health insurance and South Africa is often featured just because coverage is comparably high. But from what I've heard, there is also quite a strong private sector in South Africa. And maybe just another healthcare system which is often being put forward and compared to the Nigerian healthcare system might be India, where you would also really see a dominant private sector, or let me say certain regions within India, because then you have like Kerala and other states that obviously have more like socialized healthcare. And I do think it has massive implication in terms of universal health coverage and the pandemic, making the link here. If we look, for example, at India, and you would see that like the state of Kerala was like able to better respond to the COVID-19 pandemic, like more robust healthcare system. There are people now showing research also like comparing different regions within Italy, where you would see like a region in Italy that has had entirely underfunded its public health infrastructure, was really not as good as able to respond to the caseload with the COVID-19 pandemic. Concretely, if there was impetus, I mean, I hope so, but I mean, having looked at the Nigerian context and like having observed what the policy response was to the COVID-19 pandemic in Nigeria, I wonder, right? Because like even in the midst of the pandemic, the healthcare budget was cut. The allocation to the basic health provision fund is tied to like the federal budget, since it's a 1% allocation. So you would have like this decline in revenues, which in direct line also meant like a decline in resources for this basic health provision fund. And like there are studies that have already like been conducted. You would see like that the pandemic has also meant that many of the routine immunization programs and so on and like haven't taken place. So at least for now, I don't feel that the pandemic has given us the impetus that we would need and like actually has like led to a rethinking. But I do think that many scholars are trying to document how much better, robust universal healthcare systems are able to respond to the pandemic. So I really do hope that that might like help to like shifting away from a narrower understanding of like what universalism means back to a broader vision and version of universalism. And Opeyemi, thank you. Thanks for your question, political economy. Your research on fuel subsidies sounds great. I think also, especially since we've like now seen that like the Buhari government has kind of in hiding now gotten rid of the fuel subsidies while nobody was looking kind of. In terms of capturing these political economy elements, I mean, I was compelled, or I felt convinced that for me, the Ben Fine's system of provision framework equipped me kind of with like a direction or a guidance of going about it, because the focus of the framework is really to like not only like isolate, let me say, the use of healthcare, right? Why do people seek access? Why do people access healthcare or not? But looking also at aspects of how healthcare is being provided. So it's a really strong emphasis on looking at the entire, let me say, chain of provision, like the provisioning system. So like, is it private or is it public, matters in terms of who can access healthcare. So since I then was interested in understanding all these bits and pieces along the chain, I really like started mapping out who is involved in which aspect of healthcare service delivery. And I was looking into like the agents that like are part and parcel of policymaking, having an interest of speaking to people within the Ministry of Budget and Finance, speaking to people that are in other areas of the social protection domain, like as I was saying, the cash transfer office, speaking to like people at federal level, state level, local government level, and then also a heavy emphasis on speaking to actual healthcare providers, communities seeking healthcare access. So my way of going about it and trying to capture as much of and understanding as much of the political economy was really trying to gather as many voices and as many like representatives of certain groups that are like involved in the entire healthcare system of provision. So that's how I went about it. I'm not sure if that clarifies. Thank you.
Thanks. Laura, would you like to add anything to that?
I mean, not really. I mean, maybe I do have something to say back to what Julia was talking about at the beginning, but I don't want to kind of deprive people of time to ask questions. And I see that there is a question in the comments. So I'll maybe let that person ask and then I'll speak.
Thanks very much. Okay, so we'll come back to you straight after that. Okay. So the comment in the comment box is, I'll also appreciate if you can throw more light on the cash transfer program in Nigeria. What is the view of the political class in the south and north about the program? Is it widely accepted across the divide?
Thank you, Sam, for this question. I wish I would know. No, but I mean, what I can say about the cash transfer program, firstly, there was a new one introduced in 2015. So after the National Health Act was enacted, right? I think that's interesting also in terms of timing. And it is World Bank funded. Now, let me not say World Bank funded. There's a credit or like a loan that was given to the federal government of Nigeria to support this cash transfer scheme. And I do think the first thing I really want to say is like, it's again a showcasing of like a discrepancy between some form of rhetoric and practice, because if you have a loan for, I mean, it's like I think like the whole entire project costs are like projected for like over only a 5-year period of something more than $1 billion, right? 1.6 billion and something, and of which the World Bank has like provided a loan of 500 million. And we would have an allocation to the Basic Healthcare Provision Fund of 150 million, then we also see what's worth more, right? So I do think it's a quite clear demonstration of like the shift towards like, oh, what we want to do is means tested community. It's a combination of like geographical community and means testing. So income tested cash transfer scheme compared to like this Basic Healthcare Provision Fund, which is like kind of the small fund receiving little funding, right? So that's one thing that I think is important when we discuss this cash transfer program. If there is a division between like acceptance between the North and the South, I wouldn't know, really. I don't know. I do think, I mean, having asked around, interestingly, and I asked the question, and I went to Niger State, which is north, not that far north, but a little bit north. And then I was in Enugu and in Anambra State. And I always ask the question in focus group discussions, do you prefer a cash transfer scheme over free healthcare? And interestingly, the majority of people, both in all these 3 states, were like, no, we would prefer access to healthcare for free. And they would mention reasons saying like, if like you give a cash transfer to poorer households, they all use it for food. I mean, it's understandable, right? In the country, like 60% of people are below the national poverty line. And again, we can discuss the poverty line. But so a cash transfer scheme often, even if it's like earmarked and say like, oh, let's try and like broaden the base of people who can access healthcare by just like kind of giving households a quite still small cash transfer, right, to like cater for all these these multifaceted needs that like households have is not necessarily also something that like communities seem to want. I guess like obviously if you get like money, you will take the money, especially if you need it. But interesting for me was really to see that like both in the north, in the one northern state that I visited, and like these two southern states, that like there was quite overall a consensus that like, no, the cash transfer scheme is not going to replace like the need for healthcare to be more accessible. So that's the comment I can make to that.
Thanks very much. Well, I think given the time, I'll ask maybe both of you just to give some closing remarks, starting with Laura, and then we'll give Julia the last word. So yes.
Okay, so one of the things I wanted to comment further on, and it was also in the first question about the migration of doctors and nurses, and it relates to like the response you made about career structures. And I just think that that's a very neglected kind of area generally within development studies, and I guess African studies, is kind of thinking about the connections between kind of professional identities and the environment for professions. And I've in the past studied higher education, and there's always this kind of gut reaction on the supply side. Oh, we don't have enough skills in this. Let's train people. Let's spend money on training. And that very little times do people look at absorption and look at the kind of financial basis for skills like beyond education. And I think it's very, very important, like as much as we think about the kind of financial underpinnings of health systems or the financial underpinning of any kind of social policy, like we should also pay a lot more attention to kind of the professional underpinnings and the career structures, what makes people want to stay in a system, how does the kind of, if you're a professional, you'll not only have an identity as a kind of Nigerian or as a kind of member of a political party, but you also have an identity as like an international healthcare profession where you read international journals, you're kind of proud of your accreditation, you want to have the kind of best standard in the world, be comparable with your colleagues in other countries. And we need to think more about the kind of tensions of professional identities, I think, within development. And related to that, like when it comes to, there's all of these conversations about the colonial nature of knowledge and decolonizing knowledge production. And I think we need to think more about the kind of knowledge producer, African knowledge producers, and the kind of institutions within which they sit within the development industry. And I think I wrote in the private comments that I've been doing a research project with Mozali looking at the cash transfer program in Sudan. And this is a cash transfer program that's trying to basically replace fuel subsidies, which are very costly in terms of revenue, with cash transfers as like a way to take off the pain of removing fuel subsidies. And this is an idea that has its kind of origins in Sudan is in international institutions like the World Food Programme and the World Bank. And under the previous regime, I think that's where very educated Sudanese graduates would get jobs because they were great institutions to work in, good for your kind of career advancement. And I think that these international organizations kind of provided the kind of intellectual environment for people to think about development, think about social policies. And so when you have this shift in government in Sudan, now you have a transitional government, these are the people who are now kind of in charge of policy making. And they have this kind of dual identity as Sudanese citizens who are aware of the political environment, but they've spent the last 20, 30 years within these international professional networks. And that's, they think about social policy in this kind of way that's kind of in between this professional identity and the kind of domestic political space. And I think there's a gut reaction to say, oh, these people are just kind of neoliberal World Bank employees, but that's not really taking them seriously as kind of professionals and the kind of their intellectual thinking. And I think we need to pay kind of attention to the role of international institutions as a kind of space for the kind of intellectual class and thinking around domestic ideas around social policy. This is also something, by the way, that Thandika talked about, is that he was very critical of the fact that there had never really been a kind of conducive space for kind of a domestic intellectual class within many African countries because of kind of repression in the independence era, and then because of structural adjustment. And he was very, I think, hopeful, like seeing in the contemporary period that you had kind of the emergence of like newspapers and blog posts and podcasts which were talking about politics and talking about economy directed towards a kind of African audience, rather and having that kind of more organic, domestically led discussions around political economy. So I think that's a really interesting area to think about as kind of the professional spaces and their role in kind of thinking and ideas and the kind of intellectual debates within development within the kind of domestic sphere. And the last thing I will say is I thought it would be important to mention that there is a social policy conference happening in November that's in Thandika's honor. And I think Julia's paper would be, would really fit in with this conference. So if you've enjoyed this discussion, I'll put a link in the chat. But it's a wonderful conference and I think people would enjoy it. Thank you.
Thanks so much, Laura. It's great and very useful pointers as well. Julia, if you'd like to wrap up.
Thank you. Yeah, just to add on to Laura's last point, I went to the conference 2 years ago and it's a great space, really many interesting people, many people with different insights on social policy aspects. So I definitely would encourage that. Maybe the last thing, or just one thing I want to say, and maybe it ties a little bit into what you also said, Laura, in terms of domestic-led discussions, is I do think, and also making space for some of the absorption of some of the professional, is I guess, and that's also something I took from Thandika Makandaweer's work, is the importance of kind of looking at economic policy and social policy in tandem, right? And we've been discussing in the last few days a lot about productive capabilities and industrial policy and manufacturing sector driving this. But I also really do think there is an overlap, even if we look into medical equipment production. I mean, in our group, we were also discussing this in the morning. It's really, there are areas, and the COVID pandemic has really shown the importance of this, where you can see such a clear overlap between economic policy and social policy. And often if there is more coherence between such policies, you can strengthen health infrastructure by keeping some of these really good professionals in the country because they now have the medical equipment to actually do a good job. So really just to re-emphasize that, I think the one thing that always resonates isn't at the back of my mind is the Makandaweer's paper, where he really highlights the importance of economic and social policy making. But really, thank you so much for all the questions and for this opportunity and for the discussion and all the input. I really appreciate it. And I'm really enjoying the whole summer school and look forward to the next days.
Thanks very much. And I think it's been a very nice session. Thanks a lot. And we'll reconvene at 10 o'clock tomorrow morning for more on the group work. But thanks very much to Julia and thank you to Laura for coming on board. And I hope that we will see more of you, Laura, and on the APORDE program in future. Thanks very much.